Let's move on to anemias to include sickle cell disease through acquired hemolytic anemia. CP is an African American woman with complaints of severe joint and abdominal pain, frequent urination during the past 2 days, and knee swelling. She reports a history of feeling fatigued, but attributed it to her active lifestyle. What would you do? Well, hopefully you've thought that you would ask anyone in her family, or if anyone in her family has had similar symptoms. Sometimes anemias have a genetic link. You would obtain more information about her symptoms and her complaints. Sickle cell disease is a group of inherited autosomal recessive disorders. They're characterized by the presence of an abnormal form of hemoglobin in the red blood cells. The genetic disorder is usually identified in infancy or early childhood, is incurable and often fatal, and predominant in African Americans. It's often fatal by middle age because of renal failure, infection, pulmonary failure, and/or stroke. Sickle cell disease affects about 100,000 Americans, occurring in an estimated prevalence of 1 in about 500 live African American births. It can also affect people of Mediterranean, Caribbean, South and Central American, Arabian, or East Indian ancestry. Abnormal hemoglobin, hemoglobin S, causes the red blood cell to stiffen and elongate. The erythrocytes take on a sickle shape in response to decreased oxygen levels. The substitution of valine for glutamic acid on the beta-globin chain of hemoglobin occurs. Sickle cell anemia is the most severe of the SCD syndromes and occurs when a person is homozygous for hemoglobin S, in other words, hemoglobin SS. The person has inherited hemoglobin S from both parents. Sickle cell thalassemia and sickle cell hemoglobin C occur when a person inherits HGB-S from one parent and another type of abnormal hemoglobin, such as thalassemia or hemoglobin C, from the other parent. Both of these forms of sickle cell disease are less common and less severe than sickle cell anemia. Sickle cell trait occurs when a person is heterozygous for hemoglobin S. The person has inherited hemoglobin S from one parent and normal hemoglobin from the other parent. Sickle cell trait is typically a very mild to asymptomatic condition. The major pathophysiologic event of SCD is the sickling of blood cells. Sickled red blood cells become rigid and take on an elongated crescent shape. Sickled cells cannot easily pass through capillaries or other small vessels and can cause vascular occlusion, leading to acute or chronic tissue injury. The resulting hemostasis promotes the self-perpetuating cycle of local hypoxia, deoxygenation of more erythrocytes, and more sickling. Circulating sickled cells are hemolyzed by the spleen, leading to anemia. Sickling episodes are most commonly triggered by low oxygen tension in the blood. Hypoxia or deoxygenation of red cells can be caused by viral or bacterial infection, high altitudes, emotional or physical stress, surgery, and blood loss. Infection is the most common precipitating factor. Other events that can trigger or sustain a sickling episode include dehydration, increased hydrogen ion concentration or acidosis, increased plasma osmolality, decreased plasma volume, and low body temperature. A sickling episode can also occur without an obvious cause. Initially, the sickling of cells is reversible with reoxygenation, but it eventually becomes irreversible because of the cell membrane damage from recurrent sickling. Thus, vaso-occlusive phenomenon and hemolysis are the clinical hallmarks of sickle cell disease. As blood flow is impaired by sickled cells, vasospasm occurs, further restricting blood flow. Severe capillary hypoxia causes changes in membrane permeability, leading to plasma loss, hemoconcentration, the development of thrombi, and further circulatory stagnation. Tissue ischemia, infarction, and necrosis eventually occur from lack of oxygen. Shock is a possible life-threatening consequence of sickle cell crisis caused by severe oxygen depletion of the tissues and a reduction in circulating fluid volume. Sickle cell crisis can begin suddenly and can persist for days to weeks. The frequency, extent, and severity of sickling episodes are highly variable and unpredictable, but are largely dependent on the percentage of hemoglobin S present. Individuals with sickle cell anemia have the most severe form because the erythrocytes contain a high percentage of hemoglobin S. In taking a more complete history, CP tells you that she had one similar episode of symptoms: severe joint and abdominal pain, frequent urination during the past 2 nights, fatigue, and knee swelling, when she had an acute attack of pneumonia 2 months ago. What's unusual about her episode of pneumonia? Well, acute episodes of pneumonia may be accompanied by fatigue, but her complaints of pain, frequent urination, and swollen knees are not consistent with just pneumonia. The effects of sickle cell disease vary greatly from person to person, the severity of which may be due to genetic polymorphisms. Many people with sickle cell anemia are in reasonably good health the majority of the time. However, they may have chronic health problems and pain because of organ tissue hypoxia and damage, that is, involving the kidneys and/or liver. Because most individuals with sickle cell anemia have dark skin, pallor is more readily detected by examining the mucous membranes. The skin may have a grayish cast. The primary symptom associated with sickling is pain. The pain severity can range from trivial to excruciating. During sickle cell crisis, the pain is severe because of ischemia of tissue. The episodes can affect any area of the body or several sites simultaneously, with the back, chest, extremities, and abdomen being most commonly affected. Pain episodes are often accompanied by clinical manifestations such as fever, swelling, tenderness, tachypnea, hypertension, nausea, and vomiting. With repeated episodes of sickling, there is gradual involvement of all body systems, especially the spleen, lungs, kidney, and brain. Organs that have a high need for oxygen are most often affected and form the basis for many of the complications of sickle cell disease. One reason for infection is the failure of the spleen to phagocytize foreign substances as it becomes infarcted and dysfunctional from the sickled red blood cells. This usually occurs by the age of 2 or 4. The spleen becomes small because of repeated scarring, a phenomenon called autosplenectomy. Pneumonia is the most common infection and often is caused by pneumococcus. Infections can be so severe that they can cause an aplastic or hemolytic crisis and gallstones. Aplastic crisis can be so severe that it can cause a temporary shutdown of red blood cell production in the bone marrow. Pulmonary infarctions may cause pulmonary hypertension, heart attack, heart failure, and ultimately cor pulmonale. The heart may become ischemic and enlarged, leading to heart failure. Retinal vessel obstruction may result in hemorrhage, scarring, retinal detachment, and blindness. The kidneys may be injured from the increased blood viscosity, and the lack of oxygen, and renal failure may occur. Pulmonary embolism or stroke can result from thrombosis and infarction of cerebral blood vessels. Bone changes may include osteoporosis and osteosclerosis after infarction. Chronic leg ulcers can result from the hypoxia and are especially prevalent around the ankles. Priapism, or persistent penile erection, may occur if penile veins become occluded. The diagnostic studies that would be performed for sickle cell disease include a peripheral blood smear that may reveal sickled cells and abnormal reticulocytes. The presence of sickle hemoglobin can be diagnosed by the sickling test, which uses red cells in vitro and exposes them to a deoxygenation agent. As a result of the accelerated red blood cell breakdown, the patient has characteristic clinical findings of hemolysis, such as jaundice or elevated serum bilirubin levels, and abnormal laboratory test results. Hemoglobin electrophoresis may be done to determine the amount of hemoglobin S. Skeletal X-rays will demonstrate bone and joint deformities and flattening. MRI may be used to diagnose a stroke caused by blocked cerebral vessels from sickled cells. Doppler studies may be used to assess for DVT. Other tests may be indicated, such as chest X-ray, to diagnose infection or organ malfunction. In the case study, CP tells you that 2 days ago she went hiking in the mountains. She's sure her swollen knee is from the hike. Physical examination showed an enlarged spleen and an enlarged, inflamed knee joint. What should you do next? You would do blood work for a CBC, red blood cell indices, a peripheral smear, and a bilirubin, and an X-ray of the patient's knee. Collaborative care is directed to alleviate the symptoms and complications, minimize end organ damage, treat serious sequelae, teach the patient to avoid altitudes, maintain adequate fluids, and treat infections promptly. You would administer immunizations such as pneumovax, H-flu vaccine, influenza, and hepatitis vaccine. And you would treat chronic leg ulcers, priapism, and hospitalize if it was indicated. Sickle cell crises may require hospitalization. Respiratory failure is the most common cause of death. Rest may be instituted to reduce metabolic requirements, and DVT prophylaxis using anticoagulants should be prescribed. If it's not, ask about it. Fluids and electrolytes are administered to reduce blood viscosity and maintain renal function. Transfusion therapy is indicated when the aplastic crisis occurs. Aggressive total red blood cell exchange transfusion programs may be implemented for patients who have frequent crises and/or serious complications such as acute chest syndrome. These patients, like those with thalassemia major, may require iron chelation therapy to reduce transfusion-produced iron overload. A lack of understanding can lead healthcare professionals to underestimate how much pain these patients suffer. Patients may, because of their prior opioid treatment, may be very drug tolerant, and thus large doses of drugs may be needed to reduce the pain to a tolerable level. During an acute crisis, optimal pain control usually includes large doses of continuous opioid analgesics along with breakthrough analgesics, often in the form of PCA. Demerol is contraindicated because high doses can lead to the accumulation of a toxic metabolite, normoperidine, which can cause seizures. Patients may be experiencing different types and sites of pain. Adjunctive measures such as nonsteroidal anti-inflammatory agents, anti-neuropathic pain medications such as tricyclic antidepressants and anti-seizure medications, local anesthetics or nerve blocks may be used. Although pain is the most common symptom of patients with SCD seeking medical care, infection is a frequent complication and must be treated. Patients with acute chest syndrome are treated with broad-spectrum antibiotics, oxygen therapy, fluid therapy, and possibly exchange transfusion. Blood transfusions have little, if any, role in the treatment between crises, as patients develop antibodies to RBCs and become iron overload. However, because chronic hemolysis results in increased utilization of folic acid stores, oral folic acid should be taken routinely. Although many anti-sickling agents have been tried, hydroxyurea, which is a chemotherapy drug, is the only one that's been shown to be clinically beneficial. It increases the production of hemoglobin F, decreases the reactive neutrophil count, increases red blood cell volume and hydration, and alters the adhesion of sickled red blood cells to the endothelium. The increase in hemoglobin F is accompanied by a reduction in hemolysis, an increase in hemoglobin concentration, and a decrease in sickled cells and painful crises. Hematopoietic stem cell transplant is the only available treatment that can cure some patients with sickle cell disease. The selection of appropriate recipients, scarcity of appropriate donors, risk and cost effectiveness limit the use of HSCT for sickle cell disease. The patient and caregiver must understand the basis of the disease and the reason for supportive care and ongoing pertinent screening tailored to sickle cell disease manifestations such as eye examinations. Teach the patient ways to avoid crises, which include taking steps to avoid dehydration and to reduce the chances of developing hypoxia, such as avoiding high altitudes and seeking medical attention quickly to counteract problems such as upper respiratory tract infections. Teaching about pain control is also needed because during a crisis the pain may be severe and often requires considerable analgesia. Minor pain episodes that are not associated with infection or other symptoms warranting medical attention may sometimes be managed at home. Recurrent episodes of severe acute pain and unrelenting chronic pain can be profoundly disabling and depressing. The quality of life of patients with sickle cell disease can be profoundly affected. Occupational therapists and physical therapists can help the patient achieve optimal physical functioning and independence. Cognitive behavioral therapy may help patients with SCD cope with anxiety and depression. Support groups may also be helpful. Back to our case study. CP's lab values show a hematocrit of 30, hemoglobin of 10, white counts 20,000, bilirubin's 2.8, urinalysis is normal, ferritin is normal, and the X-ray of her knee is normal. What problem do CP's history and symptoms suggest? They would suggest sickle cell anemia, right? What patient teaching is essential for you to discuss with CP? Hopefully you're beginning to list things such as avoidance of high altitude, making sure she remains well hydrated so she maintains an adequate fluid intake, properly treats any infections, receives immunizations for pneumonia, H-flu, influenza, and hepatitis, and instruct her on when to seek direct medical attention quickly, especially if symptoms return. Now we'll move on to acquired hemolytic anemia. Hemolysis of red blood cells is caused by 4 different categories of extrinsic factors: macroangiopathic, such as physical trauma; microangiopathic, antibody reactions; and infectious agents or toxins. The physical destruction of red blood cells results from the exertion of extreme force on the cells. This can happen with hemodialysis, extracorporeal circulation used in cardiopulmonary bypass, prosthetic heart valves, or abnormal vessels. The force needed to push the blood through abnormal vessels, such as those that have been burned or affected by vascular disease, such as diabetes, may physically damage red blood cells. Microangiopathic destruction results from fragmentation of the cells as they try to pass through or by abnormal arterial or venous microcirculation. Red cells are sheared as they try to pass by excessive platelet aggregation or fibrin polymer formation. This is seen in thrombotic thrombocytopenic purpura and disseminated intravascular coagulation. 2 mechanisms involved in antigen-antibody reactions destroy red cells: isoimmune reactions and autoimmune reactions. An example of an isoimmune reaction is when, in blood transfusion reactions, the recipient's antibodies hemolyze donor cells. Autoimmune hemolytic reactions may be idiopathic, developing with no prior hemolytic history as a result of immunoglobulin G, or IgG, covering the red blood cells, or secondary to other autoimmune diseases such as lupus. Leukemia, lymphoma, or medications such as penicillin, ibuprofen, metformin, chlorpromazine, or procainamide can also cause these autoimmune hemolytic reactions. Infectious agents can cause hemolysis in 3 ways: by invading the red cell and destroying its contents, releasing hemolytic substances such as Clostridium perfringens does, which is the cause of gas gangrene, and generating an antigen-antibody reaction such as Mycoplasma pneumoniae does. Chemical agents that are toxic and can cause hemolysis include oxidative drugs, arsenic, lead, copper, bee stings, and spider bites. Supportive care until the causative agent can be eliminated or made less injurious is important for the treatment and management of acquired hemolytic anemia. Aggressive hydration and electrolyte replacement are needed to reduce the risk of kidney injury caused by the hemoglobin, clogging the kidney tubules and causing subsequent shock. To suppress the red blood cell destruction, immunosuppressive agents may be used, such as Rituxan or rituximab, a monoclonal antibody to B cell CD20, and eculizumab or Soliris, a monoclonal antibody to complement protein C5.